back. So I hope you enjoyed the posters during your refreshment break and had a chance to talk to site docs Walters Kluwer, the VCCC and the RCCC. All great supporters of our showcase and very appreciative of that. So, first session after lunch, it gives me enormous pleasure to welcome Carmel Byrne to the podium. Carmel works in HARP as a cardiac clinical nurse consultant and care coordinator and is the current national president of ACRA. You'll have to tell me what that acronym stands for. Carmel's an experienced heart failure nurse, having worked in cardiac ICU, CCU and cardiac rehab since the 1980s. She led the Safer Care Victoria Heart Helper pilot from 2022 and is dedicated to improving the lives of people living with heart failure. So please join me in welcoming Carmel.
Thank you. Thanks, everyone. So, heart failure, as everybody knows, is a major issue in Australia, with over 10% of people over the age of 70 being affected, and this subsequently leads to frequent hospital admissions. So in November 2021, HARP successfully submitted an application to Safer Care Victoria to participate in the Heart Helper pilot. Bendigo Health, in collaboration with Safer Care Victoria, the Northern and Royal Melbourne Hospitals and consumers, co-designed and trialled a new model for home-based care for clients living with heart failure. And this was mostly following a recent hospital admission. The heart failure pilot aimed to reduce ED presentations and hospital readmissions, improve client skills and confidence to self-care, deliver timely and effective care and support post-discharge, trial the use of an alternative workforce. We started with RUSONs and then went on to use ENs, identify barriers and improve patient-reported outcomes, and investigate and trial heart failure assessment and education tools. So at Bendigo Health, we actually concentrated on improving HARP admission and referral processes. So we did this through staff education, looking at follow-up, quick follow-up post-discharge and prioritising home visits. We developed new heart failure assessment and education tools. This focused on the Heart Health Monitoring Diary, Diuretic Action Plan and heart failure assessment documents for the care coordinators. And review of patient reported outcome tools. We did some research into this and settled on two tools, Partners in Health Recovery Scale and the Kansas City Cardiomyopathy Questionnaire. The home visits, we centred on quick and frequent contact. The structure of the visits could be changed as required. There was reinforcement of education, closer checks on vital signs, which was care coordinator led. We really looked at the individualised assistance for clients, looking at what they actually need. And we didn't just involve the client, we also involved their carers, but we did focus on the client. And we really worked on a collaborative care models between the care coordinators and the heart helpers. So our Heart Helper model of care worked alongside the HARP existing model of care to provide a more tailored service that supported individual heart failure clients and carers. The model of care evolved extensively based on feedback from both staff and clients. So our first box there, the intake liaison nurse, they prioritised a 48-hour phone call and did referred on to care coordinators. And then the care coordinators were left with the bulk of the work. So we did work closely with them and looked at assessment tools to make sure that because of their clinical load, we didn't overload them with additional assessment requirements. We tried to keep that to a minimum, and we shared that requirement between the care coordinators and the heart helpers. And the care coordinators were really encouraged to prioritise early assessment and referral onto the heart helper team. Myself and Janet, as the clinical leads, we maintained all the databases, but we also provided education, promoted the pilot within the hospital, and we also provided the clinical supervision to the heart helpers, especially when they were RUSONs, they required that. So the heart helpers, They aimed at 5 home visits a day. They had a shared caseload of 30 to 40 clients at any one time, but they also had primary clients to ensure that they had client-focused care. But the sharing of information was so that if one of them was away, there was always somebody there who could look after that client. Home visits by the heart helpers could range to anything from once a week up to 4 times a week. It was client-centred, and we identified what was important to the client and the carer, improved client welfare and quality of life, and they assisted with doing the discharge paperwork that was required for the heart helper pilot. Also included in all this, we made sure that clients, before they came on board, they were given information pamphlets, and we gained their consent to be included in the project. So what was our outcome? So the demographics, over the period of August 2022 to April 2024, which is when the pilot actually was up and running, we had 354 referrals. We had an 80% uptake of that referral, so 285 clients actually received at least one heart helper interaction. The median age of our clients was 77 years. They did range from 46 to 93 years of age. 43% were women, 30% were cold, and the preferred English language was English. Our total number of heart helper home visits was over 2,000, and the median length of stay on the heart helper program was 37 days. So our outcomes. The heart helper pilot resulted in some extremely positive outcomes. So the early contact, 65% of our clients were actually contacted within 48 hours of discharge from hospital, which is much improved than 25% at baseline. But the median time when we actually take out weekends was 2 days, so that was really good. Initial home visit, at baseline it was 11 days, so it was quite long. We refined the allocation model, and initial home visits improved to 7 days post-discharge. We never got it down to 5 days because there's things impacting, like a lot of clients, we couldn't contact them because they'd gone to stay with relatives, or they had multiple medical appointments and staff availability. Our big call, the all-cause hospital readmissions, at baseline, HARP admission data revealed that 30% of heart failure clients were readmitted to hospital within 30 days of discharge home, much higher than the state average of 20 to 25%. Our readmissions reduced from 30% to 14% at 30 days, and this met the pilot's primary objective and correlates also with other studies showing that early contact with clients going after being admitted to hospital actually improves that hospital readmission rate. When we look at our patient-reported outcomes, the first one we looked at is the Partners in Health Recovery Scale. We settled on this because it actually correlates with the Flinders assessment tool that we use in HARP, and it's a validated questionnaire that is based on 12 principles of self-management, and it's scored from 0 to 8. We completed this on admission and again at discharge, and this was done only by the care coordinators, and all the data that is shown here is matched admission and discharge data only. The average admission score was 62.3 compared to 73.9 at discharge, supporting the objectives once again of our program. And but overall, you can see there was an improvement between admission and discharge on all of the domains. So the most significant average change for clients was actually things like tracking symptoms, early warning signs, taking early action, and what they knew about their conditions and their medications. And this correlates really closely with what HARP does and what the heart helpers did with our model of care. So our next patient-reported outcome we looked at was the Kansas City Cardiomyopathy Score. Now, this is a validated health status measurement for people living with heart failure and cardiomyopathy, and it looked at the areas of physical limitation, symptom frequency, quality of life, and social limitations. So the data, once again, is only matched admission and discharge data only, but 90% of clients discharged from the heart help pilot demonstrated a statistically significant improvement. The average scores, which is the blue one at the end, at admission was 39.68 out of 100, and on discharge was 63.72. Symptom frequency, the orange bar, shows the greatest improvement as clients' heart failures stabilised from their pre-admission health status. But purple, the physical limitations, you can see even though it improves, it really was still the worst at admission and discharge. All clients were given the opportunity to complete a consumer feedback. You can see there's lots of really great feedback there. Our feedback form consisted of 5 questions based on how useful the program was, communication, education, support and wellbeing, and we also gave them the opportunity for 2 open questions. So they really embraced the fact that things were, they had frequent follow-up, everything was explained to them really well, and they just had somebody to check on them, so they felt more comfortable. 97% of clients strongly agreed that the Heart Helper pilot was useful and supportive for them. 2 consumer groups were also conducted, along with 2 staff focus groups. These were led independently by Shona Gritch, and the thematic analysis of the feedback revealed that a number of very positive themes that supported that we really needed to continue the program from both the staff and the client perspective. These are the key learnings. These come back from the whole of Safer Care Victoria for Victoria. So the early contact with clients post-discharge can make a significant to their outcomes, because people go home very confused, there's so much going on and they need to get back on track. To facilitate improved outcomes for HARP clients, it's really important to collaborate with other departments. We collaborated very closely with cardiology, cardiac rehab and the heart failure programs. Consumer involvement and feedback really improves client care and involvement, and self-care goals, which were set by 97% of clients, show this assisted staff to address individual patient needs through the provision of very personalised care and support. And across the state, the Heart Helper pilot successfully reduced 30-day all-cause admission across all sites. So here in Victoria at Bendigo Health, in conclusion, based on the success of the program, the positive feedback by staff and clients, the HARP PM program is now up and going, and this is available to all HARP clients. It continues to grow and evolve. They work closely with care coordinators and the clients to provide personalised support. We also trialled new heart failure assessment documentation for the care coordinators, which is now embedded in HARP, plus these new heart failure health monitoring diary and a diuretic action plan, which we work with both of these with the cardiology department, and these are now online on the Bendigo Health website and are an integral component of the heart failure care. So thank you so much to everybody from the Happy Heart Helper Hub. I'd like to thank Janet Bradley, who worked with me on this project, our wonderful heart helpers, Hannah and Sian, everybody in our management and the heart helper staff, or the HARP staff who joined us on this program. Thank you.
Two minutes for questions. Any questions? Yes, Donna. Jenny will bring the mic over. Yep. Yep.
Thanks, Carmel, for your fabulous presentation and the results, really positive results for your patients as well as the staff as well. That's awesome to see. You've talked through, I'm interested in sustainability and sustainability of the model. I'm interested, you talked through the things that are being embedded in HARP and EN, et cetera, et cetera. I'm curious to understand whether that's done with decreased resources now since the project's finished, or?
No. So one of the things that I did very early on was look at making sure that this was a sustainable project moving forward, and we're very lucky with people like Sally and Nicole and everybody above us who actually looked at where could we just find EFT to make sure that we could get this keep on going. So they did a really good hunt, and we looked at the fact that, yes, ENs are a financially viable workforce. It also has created with them a new job that these girls absolutely love. It's not ward work, it's not being stuck doing something, they just love it with a bit of autonomy. And so and we looked at how it could be funded ongoing using what we do, our Vina stats. So it was there. Thank you.
So Carmel, COPD, same thing?
Same thing. It's all the research shows that if you get out to somebody's home early and you can say, yes, you're on the right track, look, yes, you've got your medications. People end up in ED so often because they just don't know. and they get scared. So ED comes.
So do you think you need to adapt what you're already doing from a COPD pack?
Yes.
Obviously, we refer a lot.
Anybody from HARP who's in HARP now can have this program across any, doesn't matter what chronic disease they have. If they're admitted to HARP, our heart helpers are there to follow them up. Oh, HARPians, sorry, wrong name, same people.
Okay, thank you so much, Carmel. And I must admit, if you saw the Bendigo Addy recently, you would have seen two of Carmel's participants of that with their smiling faces on the front page, which was wonderful to see. So next up, we're very pleased to have Dr. Daniel, I'm not going to say this correctly, am I? Do you want to just help me out?
Wondersits, yep.
Wondersits, thank you. Daniel's the Holsworth Postdoctoral Research Fellow at La Trobe University, Bendigo, and his main area of research focuses on cardiac arrhythmia around high volume exercise in recreational athletes. Thank you, and join me in thanking Daniel.
Thank you. So thank you everyone for having me. Thanks for the introduction and being here. I'll go forward. Right, so my talk's around exercise. So we know that exercise is good for us. It can be considered one of the strongest, safest and cheapest forms of medicine that can be prescribed to improve our health. As a result, there are physical activity recommendations that have been produced that suggest we should perform anywhere from 75 minutes of vigorous up to 300 minutes of moderate intensity exercise to improve our health. On top of this, there are recommendations that not only should we be performing this amount of exercise, but we should do more for additional health benefit. And this is uncapped. So 10 hours a day, 20 hours a week, you can do as much as you want and you should get additional health benefit. When we look at our, statistics for Australia, about 1 in 5 people meet or exceed physical activity recommendations currently. And I like to think of this form of physical activity as high volume exercise. So a lot of time on a bike, running, swimming, whatever it is. A good example of people who do this are professional athletes, especially professional cyclists, professional runners, where they perform, a lot of time out on the road, running, cycling, etc. This form of exercise then leads to a lot of positive adaptations to their heart. So the hearts get bigger, the muscles are stronger, they can pump more blood around the body. And as an example of this is our cardiac output. You and me in here, probably around about 22 litres per minute, we pump around our body. Professional cyclists like Cadell Evans might pump 35 litres, 40 litres per minute around his body. However, professional athletes, especially professional cyclists, have been shown to have an increased risk or increased number of abnormalities in their heart. And I like to call these abnormalities cardiac arrhythmias. A reason for this as well is that cycling is one of the most demanding forms of high volume exercise. You've got a person on a bike crouched over, upper body holding the bars in an isometric position, so stationary, straining the heart that way, as well as the legs continuously moving, a lot of oxygen demand needed, putting a really large demand on their body and their heart. An example of the literature as well is looking at professional cyclists. This is a study of over 1,000 professional athletes, and we found that, or they found, sorry, that professional cyclists had the highest rate of distinctly abnormal cardiac or heart rhythms. And this was 6-fold higher than the general population. Further, when we look at more of a negative outcome, so cardiovascular events, a smaller population than this, but again, cyclists who are professional ranked the highest in it. So they had 41% myocardial infarction, etc., and this led to about a 3-fold increased risk over the most comparable other population being runners. So again, professional cyclists, we've got issues, potentially. But that's professional population. What about recreational cyclists? There's very, very little literature in recreational populations at all. With Bendigo Health and the cardiology department in La Trobe University, we did a study looking at just cyclists who wanted to raise funds for their charity, so they decided to fly to Western Australia, cycle for 21 days back to Bendigo, and I should have done a curved arrow. Clearly they've gone across the water. They're pretty impressive bikes. And we found when we compared pre to post, the number of arrhythmias, it was increased by 10-fold. But they have done a stupid amount of exercise when you think about it, like 6.5 hours a day, same distance as the Tour de France. So that's probably more the extreme end of, the safe, amount of exercise you can do. But unfortunately, because of being a public health system, we weren't able to get them all in the second they finished their ride. So on average, we got them in on approximately 3 days after the ride. So we don't really know what the time course is of abnormalities in the heart after such a large amount of exercise. Could it have peaked immediately post-ride and it was on the way down? Or at the 3-day mark, was it still going up? Further, a lot of literature, when they look at arrhythmias, either focus on one arrhythmia, such as atrial fibrillation, or they'll focus on a couple of arrhythmias, or they just don't say what they're looking at. So we don't really know, there's not really much out there we can compare to. There are recommendations that suggest we should look at, in particular, these 5 arrhythmias being supraventricular tachycardia, atrial fibrillation, couplets, triplets, and non-sustained ventricular tachycardia. If these are found, then they need to refer these sort of people off for further evaluation. However, again, no study in the literature has looked at these in particular, along with any other arrhythmias. So that brought us to the aims of the study which I'm talking about. We really want to look at the time course, so change in arrhythmias over time around a single bout of high volume cycling, so not just 21 days, which I'm sure we all want to do. Participants, they were healthy, currently cycling in the population, aged on average 52 years, been cycling for about 18 years, complete about 200 kilometres a week, and their VO2 was about 43 mils per kilogram per minute, so fairly fit. To look at arrhythmias, we put on a 5-lead Holter monitor, and to make sure they didn't do any exercise outside of what we wanted them to do, we just had an actigraph activity monitor on the wrist. Not that that would stop them. And so then, to really break it down, we're really interested in change in arrhythmia by day. So we designed this repeated measures study design. So we got them in on the first day, which is at least 1 day before we did our intervention. We did a graded exercise test where you sit on a bike, we look at your oxygen intake and exposure and what comes out, figure out what your VO2 max is, do some baseline questionnaires, then send them away. Then they came back in and we put on a Holter monitor, which was worn for the entire 9-day period. So that's a long day for a Holter monitor. Wore the actigraph as well. And then on day 5, they come in the morning, we do a 6-hour cycling intervention. The rest of the day, no exercise. The next 4 days after, no exercise, and to look at change, if there was any, in arrhythmias. To break down what they did on the exercise day, it's shown on the slide here. So we broke the exercise bout down into 6 bouts of 50 minutes of cycling, and then we gave them a 10-minute break. Because it was in the lab, they're on a bike, it's not like they could stand up and go around or just cruise down a hill. It was continuous cycling, so we really needed to add the break in. During it, we monitored heart rate to ensure that they're actually exercising at the intensity we wanted. If it started to go down, we increased the intensity. If it started to go up, we reduced the intensity. We also monitored rating of perceived exertion. We gave them a supplement, a drink supplement, so they had the fluids, the carbohydrates, and the electrolytes they would typically need to perform high volume cycling. And again, the Holter was worn throughout, so it was not taken off, except for when they went for a shower or a swim. Although they shouldn't have swum because we said no exercise. So then after the 9 days, when we got them back in, or we grabbed the monitor, we downloaded it, we had a cardiac technician who screened the data for all arrhythmias, as well as the 5 that we were interested in. Any that were identified were sent to the head of cardiology at the time here at Bendigo Health to verify that these arrhythmias did occur, and then we broke it down by day to see what the prevalence was by day. We used SPSS to analyse the data, and we were interested in all arrhythmias overall, as well as whether they occurred in the atrium or the ventricles, to see if there was a cause there. The data being, it was a smaller sample, so therefore it was not normally distributed, therefore we had to use non-parametric statistics, so we used dichotomous Cochrane's Q test, and we used the Mecklenburg test if there's any significant effects by day found, and we compared just to the exercise day, so yeah, let's see. So what did we find? First, the amount of exercise, the prescription was really good. We can see a really consistent trace with the blue line being heart rate, maintained throughout. Intensity was the grey line, and that was fairly much maintained throughout. I had to drop it down a little bit near the end because people struggled. RPE significantly increased every hour as they went through. So from a prescription point of view, really happy with the intervention. Overall, 9 days of monitoring, we monitored over 28 million heartbeats. We found almost 280,000 cardiac arrhythmias, predominantly premature ventricle and premature atrial contractions. Those 5 arrhythmias of interest, over the 9 days of monitoring, 68% of our participants displayed at least one or more of these. So these are people in the population now cycling with these. And on the exercise day alone, there was 38% displayed one of them. When we broke it down to the data to see if there was any difference compared to the exercise day, it was only the ventricular arrhythmias that were abnormal that we found on the exercise day that were significantly increased compared to most days pre-exercise and the day after exercise. So just those 3, sorry. When we look at the 68% number, which was quite high, and compare it to the literature, which again is really hard because it's not very detailed, runners typically anywhere from 0% in some studies to 17% found, professional or recreational. Cross-country skiers, 22% have been found as the highest number. And then that study I talked about previously, which they did the 21 days, it was 27%, well, 3 days after. But I guess the high rate of 68% is somewhat explainable. We've monitored them for 9 days. These other studies typically were for, 1 day, or even if they did a 12-lead ECG, it's 10 seconds of data. So it's really hard to compare 9 days to that. The number of arrhythmia we're looking at least 5 arrhythmia, whereas other studies might have just done AF. So hence our percentage is higher again. And the mode of exercise, there's definitely a trend with cycling having higher rates. But when we compare the rates themselves, looking at the bottom, I can't see the pointer, but the bottom little graph there, anywhere from 9% up to 34% on a day, which is comparable across the literature. Other things we found as well was that if you displayed any of these arrhythmias before you exercise, so in those 4 days of monitoring before, if they had it on one of those days, or 1 or more days, or 2 or more days, your risk of displaying it when you exercise was dramatically increased, which somewhat makes sense. Thank you. We also found that if you had premature ventricular contractions and a high number of these before exercise, it was associated with having it on the day of exercise, and also increasing age was also associated with this, which makes sense as age is a factor with arrhythmias. Oh, fancy that the S has moved down. Not playing the blame game. It's my fault, probably. So just to break it down, I've actually got some text so that we can read. So, I can't remember what I was going to say. So 9 days of monitoring around a single bout of high-volume cycling identified a high rate of abnormal cardiac arrhythmia. The proportion of participants who experienced abnormal ventricular arrhythmia was elevated on the day of exercise alone. The risk of abnormal cardiac arrhythmia on the exercise day was associated again with that pre-exercise appearance, as well as PVC number and age. And this brings about, thoughts around future research and current screening practices, which might not be adequate to identify individuals at risk of abnormal ventricular arrhythmia, especially pre or during high-volume exercise. Hence, future large-scale studies are warranted to determine the prevalence of abnormal cardiac arrhythmias in recreational athletes. Because this is a smaller subset, we might have just been lucky or unlucky to find people that had more of these issues show up. Hence, I'm currently planning to do a future study, which is right now, so 30 seconds on this, where I'm screening anyone pretty much 18 years plus, as long as you don't have a diagnosed cardiac arrhythmia. We want to bring you into La Trobe University in Floro Hill. Hour and a half, we'll give you a graded exercise test, tell you how fit you are. 12-lead ECG, put a Holter monitor on for 2 days and another monitor for 6. And we're just going to, you can do whatever you want during those 6 days, cycle, run, not swim. And then we'll tell you if we find anything interesting. We'll follow you up a year after this, etc., etc. So we just want to see if the rate stands, So 68% is it the same in this population? And anything we find, we'll pass on to you straight away to action as you want. So thank you very much for your time.
That was very, very interesting. That makes me so pleased that I'm not an elite cyclist or even a recreational cyclist.
Getting up from the couch to the fridge, if you do it enough times, that could be endurance exercise.
Questions? Emma?
So 2 questions. One, has it altered what you do as a cyclist? And secondly, does it actually matter?
No, it hasn't altered anything I do, and I don't do enough, so I'm in that the 4 out of the 5 who did an exercise. And the good question is, does it matter? So there's not really a strong association saying if you find one of these arrhythmias, it's going to lead to sudden cardiac death, for example. But we do know that if you do have arrhythmias, there's potential functional changes that can occur, fatigue, if it's sort of non-sustained or towards that. So I'm still not quite clear on if you appear with this, what it actually leads to, but that's where the next study comes to, and then potential future studies where I want to look at interventions to say, if you have this, can we reduce what you do, increase what you do? Functionally, how are you feeling on those days? Have you improved? Do you, et cetera, et cetera.
Thanks for the great talk. Was there any report of whether the arrhythmia events for the patients were symptomatic at all?
And so no one reported any symptoms prior to this. We did give them the ESSA pre-screening questionnaire. So I think 3 had said ever they'd felt faint, dizzy, etc. But that also is quite a broad question, so not really specific to, exercise and the heart. So like my next study, we've got a more specific heart questionnaire as a result based on that. And if they had have done that, they would have had to have been screened by either their doctor or a cardiologist to be able to participate, or would have been excluded. Sorry.
So when you look at the outcomes of this, your research, would you recommend people doing this kind of average average man, wearing, say, a really good high calibre watch while doing high-intensity exercise.
A lot of the new technology is moving in that direction as well and potentially can monitor some of the more common arrhythmias, such as atrial fibrillation, and give warnings with that. So yeah, I definitely would recommend that. I suggested it as part of, we're running this up at the moment, so I've had that as a suggestion. We can move forward to maybe wearables and less burden on the health system, instead of just coming in thinking they found something when they might not have.
One more.
Can I ask, was there a threshold heart rate at which you found that the arrhythmias occurred, or if they stayed under a
Yeah,
certain...
so I didn't break it down for specifically that because, yeah, that would have taken more in-depth analysis, but it is interesting to look at that. The graded exercise test we're doing as part of the next study, we've got the halter on for during that, so as you're going harder and harder, your heart rate's going to go up. So we'll be able to have a look at that at least. If something comes out of that, I'd really like to follow that up, because if I'm going to do an intervention, I don't know if it is actually intensity, if it is the duration, or it is the frequency that really contributes to the potential appearance of things.
I think it'd be really interesting to know if it was heart rate related or VO2 max related.
Yeah, so we did run some regressions to look to see if VO2 max was related to it, and it wasn't associated with the people that displayed it on the exercise day anyway. So when you compare the people that didn't have it on that day to the ones that did, there was no difference between the groups.
Thank you. And I'm sure we can ask and have answered some more questions during the afternoon tea break, hopefully. Daniel, thank you very much. So on that path, we now introduce Blake Collins. So Dr. Collins is an early career researcher interested in improving exercise engagement and prescription methods for people with cardiometabolic conditions in regional areas. Research to date has demonstrated the prognostic effect of exercise among patients with coronary heart disease that may inform future models of care. So, welcome, Blake.
Thank you. Well, thank you for the kind introduction, and thank you all for your time this afternoon. So I'll be presenting on integrating motivational, interviewing and cognitive behavioural therapy into regional cardiac tele-rehabilitation. So we have a lot of scary statistics around cardiovascular disease, and I'm sure most of you are already aware of them working in the field, but the one I would like to draw your attention to is that currently 1 in 6 Australians have cardiovascular disease, which is approximately 4.5 million people. Now that's a scary statistic as it is, but what we know about readmission rates is approximately 1 in 4 of those people with cardiovascular disease will be readmitted into hospital, which then puts additional stress on healthcare and adds to the burden of overall cardiac prevalence. Currently, what happens with those individuals that enter into the cardiac space is they go through a rehabilitation process. So that is a multi-phase and multi-stage intervention, and it's got lots of different dynamic elements, but the ones that we're predominantly interested in is the exercise training and physical activity counselling. The reason we tend to focus on that is we know that if you improve your cardiovascular fitness, you'll decrease your risk of all-cause mortality. So this was a study done in the early 2000s where they looked at a follow-up of over 10,000 participants, and they split them into what we'd consider healthy and then cardiac participants. And what we realised is as you move from left to right, regardless of whether you had cardiovascular disease or you didn't, as you improved your cardiovascular fitness, you decreased your relative risk of death. So as you get fitter, there's less likelihood of an adverse event. Unfortunately, despite that established relationship between exercise, physical activity and decreased risk, approximately 50 to 80% of people that are eligible for cardiac rehab will get a referral. Of those that get the referral, about half will actually enrol in the program, and of those that enrol in the program, another half will actually complete the program. So if you have 10 participants, you're going to have 2 that actually finish the program and get those benefits. So because we know that there's some kind of limitation, there has been some research that has looked at what are the barriers, and what they've consistently identified is logistic barriers. So we're talking about things like cost, lack of access, travel distances, logistic issues and scheduling, and all of those factors are exacerbated in regional areas where we have reduced resources and bigger travel times. So with that, a pragmatic or a common sense approach would be the integration of telehealth programs. Now, I'm sure everyone's familiar with telehealth programs. They've been around for a long time, but obviously with the restrictions that we had with COVID, with face-to-face services, it was an acceleration of incorporating them into healthcare. But we do have some questions around their usefulness in terms of their application to behavioural modification. So not just in terms of a conference call or handing over results, what's their actual application when you're trying to modify behaviour? And we also have some questions around if it is applicable to modify behaviour, what's the exercise fidelity? Like, do we know if the participants are actually completing the exercise, or when you ring them, they're just saying, yeah, I went for my walk and it's all good. So we have some limitations around that. So what we decided to do was trying to incorporate behavioural integration or behavioural change approach. So we used motivational interviewing and cognitive behavioural therapy. Now, if you're not familiar with MICBT, it's essentially around trying to encourage the participant to make these positive choices and come to those conclusions on their own, rather than being told, hey, this is good for you, go and do it. So we come up with a 6-week intervention where each week we'd have a particular topic that we'd want to discuss, whether it was around their motivation to exercise or barriers to exercise. We had different topics, and we would use techniques such as open-ended questions, reflections, summaries to try and encourage the participant to come to their own kind of conclusions regarding exercise. So with all that in mind, we designed a process that wanted to look at what is the effect of MICBT supported telehealth programs on exercise fidelity, and then what was the effect of MICBT supported programs on cardiac health. So to do that, we had freely volunteering participants that are eligible for cardiac rehab in the Bendigo area. We did some baseline testing, which included questionnaires, Holter monitoring to look at heart rate variability. We did a tigraphy-based sleep assessment. We also looked at your conventional blood analysis, things like triglycerides, cholesterol, glucose. And then we did a cardiopulmonary exercise test, which is pictured there, which is what measures your cardiorespiratory fitness. The data I'm presenting today is one arm of a larger project, so they were randomly allocated into this group. The actual intervention, what it looked like, so we're doing aerobic exercise. So we'd start off with a 5-minute warm-up. We then do 30 minutes of continuous aerobic exercise at the workload equivalent to the ventilatory threshold. If you haven't heard of the ventilatory threshold before, it's essentially the part where you cross from your aerobic workload into an anaerobic workload. And that threshold has been demonstrated to not only be effective, but also safe and tolerable among cardiac rehab patients. So what we did is we used that cardiovascular fitness test with the mask on. We identified where the threshold was and what that equivalent heart rate was, and then we said to the participants, your heart rate is 100 that you want to aim for while you're exercising. We prescribed this 3 days a week for 6 weeks, and they had a weekly supported MICBT session that would touch base with them, see how they were going, what their barriers were, and to check in on the progress they'd made. We use Polar Flow, which is a freely available program that can track your exercise programs, and it was accessible by the research team. So every time a participant did a program, we could actually see what that was, see how long they exercised for, and the heart rate they were at. And then when we finished the 6-week program, we did the follow-up testing by repeating those measures. Statistically, what we were interested in is we wanted to break down exercise fidelity in terms of what was their adherence, so how many sessions did they complete out of the 18, but we were also interested in, of those sessions, how accurately did they actually did they exercise to the prescription? So in terms of time and intensity, were they abiding by the rules or the prescription that they were given? And we also looked at some paired sample t-tests to compare pre to post changes. So this is there's still some ongoing results. We're still collecting some data, but for the 20 participants that have finished, that threshold I spoke about, the ventilatory threshold, it worked out to be at 105 beats per minute on average for the group. And what we've found is that of those 20 participants, they would exercise on average at 106 beats per minute. The training time was that 30-minute block of continuous aerobic, not including your warm-up and cool-down. And what we've found is they're exercising in about 40 minutes in duration, so it's above what we prescribed. And of the 18 sessions, they're completing 17. So it's difficult to compare our results to previous work because previous work hasn't really unpacked the exercise the same way we have. They generally just go session attendance or non-attendance. But that is really good fidelity. To have the correct intensity for a longer duration and 17 out of 18 sessions is fantastic. In terms of the predominant measures that we looked at for cardiovascular health. We haven't measured all of them, but the ones that we've looked at so far, cardiopulmonary exercise test, which is that fitness measure, and it's the one that predicts future all-cause mortality. We have seen that they've increased their fitness from pre to post by 1 mil per kilogram per minute. This change hasn't reached statistical significance, but it is the clinically important difference from pre to post, so it has clinical implications when you improve your fitness by that amount. We then also looked at a couple of questionnaires, and one of them was the short form 36, which is it's a questionnaire that looks at all different aspects of participants' health and broken down into things like your physical health, social health, the limitation that your current condition has on your social and physical function. And what we've found is that from pre to post, that these measures have both significantly and clinically significantly improved. So the participants' subjective assessment of their own health has improved from pre to post. So in terms of the conclusions we've drawn, I'll bring your attention back to the initial aims. So the first aim was that we wanted to see if that MICBT telehealth could affect or improve exercise fidelity, and we've found that it has facilitated high exercise fidelity, which we've seen from the adherence rates. And we also have concluded that Polar Flow, which is again a freely available, you can download on your phone today, is a great monitoring program, and it may even increase adherence to these programs by providing real-time feedback so that participants could actually see their heart rate while they're exercising. The next aim was we wanted to see if telehealth, MICBT supported telehealth could improve cardiac markers, and we found that it did exercise intensity prescribed at the ventilatory threshold. It's tolerable, and we've come to that conclusion by the high fidelity and no adverse effects. And it also has clinically improved our key markers. We've also found that telehealth subjectively improved functional status, which again I think is really important. If we want to improve buy-in on participants' behalf, we want them to feel like the intervention's actually doing something, not just give them a piece of paper that says, congrats, you're fitter now than you were before. So future directions, I did mention that this is only one arm of a larger project, so we want to look at are these results non-inferior to a supervised program, so if we compare it to your conventional approach. We also want to know, are these results repeatable among a wider range of cardiac patients? So as I mentioned, only 20% of participants are completing the programs, and that's who we enrolled from, so maybe they're a bit more motivated than the standard. So can we apply this to a wider range? And finally, we want to know if these telehealth strategies can be improved through the incorporation of things like AI and web-based programs so that we can provide rehab programs with additional resources to help, with that lack of resource in regional areas. I just want to quickly acknowledge the research team. This obviously isn't done by any one person, so I acknowledge the research team and the ongoing philanthropic support of Dr. William and Miss Carol Holsworth, also the Bendigo Health and St John of God for recruitment. Thank you.
3 minutes for questions. Okay. Questions? Carmel.
Congratulations on some really good research when it comes to cardiac rehab. Somebody who's worked in the area for many years. Have you also looked at some of the work that's been done through Solve CHD in Sydney and Queensland with very similar projects looking at increasing cardiac rehab through telehealth engagement?
I haven't. I've done some reading with some previous research, but yeah, I haven't. I'd love to collaborate with some of those bigger projects, get bigger access to those kind of resources. One thing that we've tried to focus on that may not be helpful with those bigger programs is the application in regional areas. So a lot of our research has that kind of regional spin on it. But yeah, it'd be great to get some collaboration and potential resources there. Thank you.
Any other questions?
Don't know if that's a good thing or a bad thing.
I think it's...
Thank you.
Very good. It's been excellent. Thank you very much. It really is interesting to hear, from our academic partners that are working with our local health services and in the regional areas that are coming up with all these really interesting and often almost groundbreaking results. So thank you both very much. And it's my great pleasure to welcome Dr. Owen Howlett to the podium. Owen is an occupational therapist working in Bendigo Health Outpatient Neurological Rehab Clinic. And I know that he also has extensive research experience, and especially in translating that into practice. Welcome, Owen.
Hello everyone, it's very nice to be here. So we did a project, actually before I tell you about the project, I'd like to acknowledge our co-authors Steve Barrett, who's sitting over there, and also Tracy Harnety, who works in outpatients as well, so they helped me out with doing this. Understanding the use of telehealth in an outpatient setting. So COVID came along, as we all know, and it changed how we were doing things in outpatients. So before COVID, everything was happening face-to-face. After COVID, it gave us an opportunity to deliver rehabilitation services in our outpatient setting through a telehealth platform. So once things had resumed to normal, we asked a couple of research questions, and they are, what are the patterns of telehealth in outpatient rehab services in the past 5 years? We actually didn't know. We didn't know if we'd actually increased our use, or we're using it, or we were sustaining the telehealth practice that was established during the COVID pandemic response. So we actually had an impression and a hunch of what was going on, but we really had no idea. We also wanted to know what were the barriers and enablers to help us with the sustainability of the use of telehealth to deliver interventions of rehabilitation by allied health staff. So what we did two things. We did a retrospective analysis of routine collected data at outpatients. So we went into the databases and found out what mode of delivery we have been actually delivering outpatient rehabilitation. Then we conducted 5 focus groups with 31 staff members at outpatients. We had an average of 6 participants per group, and there was 7 disciplines represented out of 10. So quite a good cross-section of representation. What we found was this. As you can see in the first column with the pre-COVID data, that face-to-face is the top row. So pretty much most of our delivery of service was being face-to-face. The next row down is the blue line, and that was telephone. So we were doing actually quite a lot via the telephone, but of course not as much as face-to-face. And right down the bottom was a very flat line of video telehealth. So not a lot, but it was being used. COVID came along, and as you can see, face-to-face dropped immediately. And then it went up and down depending on the restrictions that were in place. You can also see that the phone contact to deliver intervention actually also went up dramatically to begin with, and then it did reduce. Video telehealth increased, but not greatly, but it did increase a little bit. As you can see, our posts, once restrictions were lifted and we could go back to face-to-face interventions, you can see face-to-face resumed, but not as high as pre. You can also notice telephone has actually increased as a standard delivery of service. And video telehealth, well, it sort of almost flatlined as well. So it didn't actually uptake. It did actually increase by, it doubled, but that double was only from, it was 0.3 and then it went up to 0.6. So still not a lot. So we were wondering why. Why is this the case that we're not actually using a mode of delivery that is actually available and set up to be used at, for rehabilitation? So in the focus groups, we use this framework to help us understand what people were saying. So if you think of the behaviour as being the use of telehealth, we wanted to know if people felt capable, motivated and had opportunity. So we used the thematic process to actually to understand why people were or weren't using this lens of the COMB framework. What we identified is that there was loads of barriers, and you can see some up on the screen. Just for a couple of examples, I think I could be doing more than what I am currently, or it feels like it reflects me personally when things go wrong. It doesn't come across as professional. Or there's been an IT issue on their end, then it's turned into a telephone call of me trying to problem solve their IT issues, and then that's half an hour gone of an hour appointment. So lots of frustrations. And when we looked at the themes, these were the 6 themes that we identified. So they felt there was a lack of specific training in how to use telehealth, which was a little bit incongruent with what was believed to be done in outpatients. There was a belief that there was training there, so there was that inconsistency. Clinicians also felt like they didn't quite understand the research knowledge, and there was also a preference for face-to-face appointments due to a clinician's decision-making process. So it was almost the default automatic thing to do, a face-to-face. And some clinicians felt uncomfortable with telehealth. As one of those quotes said, they felt uncomfortable. It was not professional when it went wrong. So there was almost an embarrassment process going on. And there was also concerns about managing risk, leading some clinicians to prefer face-to-face appointments. And that was in relations to people doing balance work or falls education online, having a person to stand on one leg when the clinician's like at the other end of the computer. So they felt less control of what the person was doing. But there was enablers as well. They did identify good things. So the clinicians, they identified I'd happily do a subjective over the phone, preferably video telehealth. So there was an acceptance, there was a willingness to use telehealth. If I'm wanting to do telehealth, it's usually because I'm wanting to see them more than once a week. Or I think when they bring up a barrier, I say there's telehealth and we can do it this way. And that seemed to be the biggest key. If there was identified benefit, telehealth was more likely to be used. So the enablers, so providing telehealth equipment and platforms definitely gave clinicians choice. So the stuff that was set up, clinicians knew it was there if they chose to use it. We also found that improvements in confidence did come through skill building. When clinicians spent that time to develop their own skill, they were more encouraged and enthusiastic to use telehealth. We also identified that when the telehealth was integrated into standard processes, it was more likely to be used. So there was some clinics within the outpatient setting that developed more the use of telephone as part of standard practice. So it was used way more. And the last enabler was clear purpose identified by clinicians for delivering sessions online, as I was saying before. So we discovered that telehealth by the video wasn't being used as much after COVID pandemic, but telephone use had gone up. So we also identified there was barriers. So what did the data tell us? What should we do about it? So there was 6 things that the data told us. It explained that we need to provide more education about actually what the research is saying about how telehealth can be used effectively to improve outcomes for our patients. And we leveraged off another research project that Steve and I completed, looking at bringing all that literature together. So we're using that literature to help with our education process. The data also points to training, skills-based training, to actually help people learn how to respond when those technical glitches happen and how to do it in a professional way so they don't feel embarrassed. We looked at education, or will look at education, to expand clinician awareness to what interventions. So it's not just about turning on your telehealth, it's all about how you actually deliver your intervention in a different medium when you're on telehealth. It's not the same as face-to-face for some interventions. The data also suggested to look at modelling, so looking at those clinicians who are using it regularly, and there are clinicians within outpatients that probably could be considered to be more high users of telehealth, so looking at using their stories and their examples to help that modelling of use. Also looking at environmental restructure, looking at, do our telehealth rooms, are they actually good? Are they effective? And also just looking at general what's called enablement strategies to support clinicians to use telehealth. So, what next? So we're currently doing what's called a community of practice at outpatient rehab. So we've got 10 clinicians representing all the streams of our rehabilitation service. And we're learning what the research literature is saying together. And then we're disseminating that across the whole outpatient setting. And then next year, we're looking at targeted training, so skills-based training, and then targeted education as well, and looking at those environmental restructure and enablement strategies. So thank you for listening. More than happy to take questions.
Questions?
Hi, thanks. Hi, Owen. Great presentation. Very interested to see what has the uptake been since you've introduced this from the patient perspective, and have you thought about possibly interviewing patients as well to see whether they are more likely to take video versus phone, and then that might help support?
Yeah, thank you for that question. So the patient's voice is the one thing that we know loud and clear that's not in our project, and we haven't yet addressed that. We know from the literature about key findings that there's benefits and acceptance in a outpatient rehabilitation sort of setting, but we haven't asked our clients. Yeah.
We've obviously used telehealth in a clinical setting as well. One of the big barriers we've found in our patient cohort is that many of our patients who are quite elderly don't have internet access and are not happy to use digital platforms. And that has been a real barrier for us. What's your experience and how do you get around that?
So in the focus group, that was also identified as one of the biggest problems, and it actually led to that. That was one of the decision-making processes of clinicians deciding not to offer it. So sometimes the clinicians made the judgment call that because they thought they wouldn't accept it, they just didn't go there. How we've addressed it, we haven't yet. That's next year.
Thanks, Owen. Great presentation. Just around the clinician and the decision-making process not to offer telehealth, did you have a sort of an age range of the difference in clinicians?
Of clinicians? We did have, this off the top of my memory, we did have some new graduates as well as people who had been out in the workforce much longer than me, and I've been out in the workforce about 27, 28 years. We didn't make that comparison.
When you're rolling it out, is there going to be anything looking at the administrative burden of telehealth, because it pushes a lot of the workload onto the clinicians?
Yeah, so that was also one of the decision points of not to offer it because of the expression of making the appointment, making sure it's going to happen, making sure the room's all set up, felt like that's providing an overburden. But we haven't yet addressed that. Yeah.
Hey, thank you very much, Alan. And again, I'm sure we can follow up some questions in the afternoon tea break. Really interesting though, isn't it, that telehealth goes right up when it has to and then levelled out. Great graphs. Now, great pleasure to introduce Dr. Stephen Barrett, who is an allied health research and knowledge translation lead at Behaviour Health. Steve's research interests include health behaviour change and preventative health, with particular focus on changes in physical activity and health economics. Two rather different things. Welcome, Steve.
Thanks, Ange. All right. So thank you for that, Ange. So I'm going to talk about a study we published this year. So looking at the cost effectiveness of delivering behaviour change interventions to improve physical activity. So we published this study earlier this year in the International Journal of Behavioural Nutrition and Physical Activity. It's open access, so if you want to have a read tonight, it's pretty good. And so quickly, thank you to co-authors on this and a couple of Bendigo Health staff, so Jack Lawrence, Josh Nitske, who's his first publication, so that's good to have him on board, and Gabby Barrett. Okay, so we all know that, physical activity is a wonder drug. It has almost no downsides, numerous benefits. However, we know that a lot of the population don't do enough physical activity to reap those benefits. So, because we don't have enough people doing physical activity, people like myself and Blake are doing interventions to try and get people to do it. And we tend to try, we're moving more into the behavioural stuff. So not delivering specific physical activity sessions that people come, we're trying to get the motivation to make that long-term maintenance. So, some of the behaviour change interventions are good, effective, like ours. But, if we have a lot of people who need them, how do we pay for it all? And there's only so much funding out there. So how do we work out what's good? So as well as, effectiveness or studies, we need cost effectiveness. So we need to know if we do things, are we getting bang for your buck? Okay, so that's what this one is really all about. So what we looked at, because, cost-effective analysis are becoming more common, it's more of a recommended part of research, then there are more and more studies coming out. So what we want to do is look at the literature and find out, could we summarise what are the overall findings around cost-effective analysis for behaviour change interventions to improve physical activity. So we searched 5 databases. We looked at community dwelling adults, free living adults. Essentially, you couldn't be a hospital inpatient, you couldn't be living in a nursing home facility. So it's trying to mirror sort of the most free living population. The intervention was behaviour change interventions. So, for example, if it was an exercise intervention, if you came in and you were given structured exercise and you went home, that wouldn't be included. It had to have a degree of behaviour change interventions, behaviour change techniques, usually delivered via sort of a health coaching medium. Compared to usual care, we were really interested in changes in physical activity. So that was the main area. In economic evaluations, usually things are measured in changes in quality adjusted life years, or essentially your quality of life. So that's pretty much a standard measure in health economic evaluations. So the good thing about that is because it's a standardized measure, you can compare what happens in your study to, say, a behaviour change study. You can compare changes in quality of life in that to maybe a pharmacological study. And it makes it somewhat comparable because it's got the same outcome. In terms of the studies we included, so it had to be an economic evaluation of a randomised trial. So you conduct a randomised trial and you do an economic evaluation alongside that. So you couldn't, so sometimes in economics they do modelling, so they capture data from a big data set. They know some of the costs and inputs and they model it over time. So that we didn't include them. It had to be a randomised trial with costing data associated with it. Everyone clear on that bit? Yeah? Okay. So we were really interested in what the quality of the economic evaluation is. So we did that using the checklist. It has 19 points on a yes or no basis. The more yeses, the better. Then we applied a new model. So one of our co-authors was the first to use this grade-style approach. And they used it on falls prevention, and now we've used it on this. So now we apply 26 different categories to that, and we put a rating on that, and we get a low, medium, high quality. So in the checklist, they think of, is the economic perspective, so do you factor in, I should have thought about how to explain this. So if a hospital pays for something, pays for intervention, like Behaviour Health pays for our interventions, then you want to measure what are our inputs, all the staff that put into it, and then what are the costs borne, so the patient costs, the health service costs, yeah? That's a health service perspective. If you want to go bigger, you go society perspective, and you capture everything. So what you deliver, the person's, as in what services they use at Behaviour Health, what service they use at the GP, what services they use everywhere. So you can get, it's the biggest one. So in the checklist, if you don't have the best one, you don't get a yes. So it narrows studies like ours that are kind of small, whereas the grade style approach, we really want to know, is the perspective chosen fit for purpose? Is the trial sort of credible? Is it applicable? So it broadens a sort of a narrow perspective of the check into something that can be used more in behaviour change intervention. So we're the first paper to do this. So, you know, nobody's complained so far. So that's the kind of crux that we're going through, and we're able to give it low, medium or high certainty around the evidence for that. Okay, so pooling it together. So lots of studies over a number of years, so we try to convert them to a single currency in a single year to allow you to compare it. We had to take authors' conclusions on whether things are cost effective or not, because different studies, we couldn't say that they weren't saying it's true if they've done their analysis. Where possible, we tried to standardize physical measures. People measure physical in different ways, steps per day, minutes per week, and so forth. So when the data was available to us, we were able to standardize that into a measure, and I'll show you that. And we synthesized by quality adjusted life years too. So we screened about 2,500 studies. We ended up with 16. The average check score was 15 out of 19. So, you know, decent standard. In the certainty, we had 14 that had a medium certainty. 1 was low and 1 was high, but on average, the 13. Okay, what was involved in the intervention? So they were quite different. So, you know, the median went for 26 weeks, but, you know, wide range. 7 sessions, again, a wide range. The average, or the median cost was $313 US dollars per person. But again, some as low as 83, others up to 1,200. But again, if you're delivering lots of sessions over a long period of time, it's going to cost more than the alternative. Of the studies, 10 used a theoretical framework, okay? So for the behaviour change intervention, so now we're talking about motivational interviewing, cognitive behaviour therapy. So a clearly defined framework. The other 6 didn't, talking about, they just called it health coaching, telephone coaching. So you don't really know what they're doing. They're doing a behaviour change intervention, but you couldn't really replicate it. Of the 16, only 5 used a measure of fidelity, so where you do a specific fidelity measure to say what you're doing. So if you're delivering motivational interviewing, best practice would be you have someone either sit in or record your sessions and assess you against an actual sheet to make sure you're delivering what you say you're doing. Yeah, you can say you're delivering motivational interviewing, but if you're not delivering with fidelity, you're not really doing it. Okay, in terms of physical so we had 8 studies that gave us data, 6 according to the authors, for them, that the behaviour change intervention was a cost-effective way of improving physical. So not bad, 6 out of 8. We were able to pool physical data for 8 studies, okay? And then what we did is, okay, let me think of this. If, it sounds like I haven't prepared. If you, let's say you want to pay for something, right? So we want to pay for a new drug to decrease blood pressure, yeah? So there's a certain willingness to pay. 1 minute. There's only a certain willingness to pay. Some people will pay for things, okay? So let's say if you can produce a drug that decreases blood pressure by 10 mm's for $50 per patient, you would say, oh yeah, we're willing to pay that. Yeah? But if it was $50,000 per patient, you'd be unwilling to pay that. You know, it'd be a lot. So we wanted to know, what are you willing to pay for physical activity? We applied a threshold to that, and within that threshold, only 3 of the studies would be deemed cost effective. Okay? So an author's conclusion, 6 out of 8 via our threshold, 3 out of 8. Better rush through. In qualities, 11 studies, only 5 were effective. Here's the threshold we applied, and a couple of studies here, a couple of good ones there by Barrett et al. That were in the threshold, you know. Okay, so varied studies. The intervention was effective. Structured physical activity sessions cost less, but they were proven to be not cost effective. Workplace interventions, unsure about it. Pooling brings uncertainty. A quick one for you health economists out there. For quality of life, if you have a drug study and everyone starts here at a certain thing, you give them a new drug and boom, their quality of life improves and off you go, whereas the control guys stay, and you're paying for all of that. In behaviour change stuff, usually everyone starts okay, and what happens is the control group drop over time. So the change here is the attenuation. So you're not getting a big boom, yeah? So if you think about our qualities didn't really change too much, only 5 out of 16, but whereas if you give someone, you know, a knee surgery, they're going to boom right up straight away. So it's not really apples with apples. Okay. We need to improve reporting, better measuring what we do, better doing fidelity. If we could do a common physical activity classification, we could be able to do a better standardization of things. But overall, there's moderate certainty that these interventions are good. So let's keep trying them. Thank you. I was faster when I practiced.
Good with timing. Questions? I was waiting for where you're going to pay me to exercise. To me, that's effective. Any questions there? No, you've explained it well, and everyone's going home to read that article that you were referring to.
Read the article and send me an email.
Okay, thanks very much, Steve. Now, do we have our next speaker? Yes. That's right, yes. So it now gives me pleasure to introduce Ryan Evans, the Senior Clinician Physiotherapist at Bendigo Health. Ryan's got lots of quals in physiotherapy, pain management, sports and exercise physiotherapy. And welcome, Ryan.
Beautiful. Thanks, Ange. Thanks, R&I, for having me along today. Just going to give a bit of an update. It's a bit of a work in progress, so have a chat about what I've been up to and where this is going to progress. So currently running a pilot trial titled Digital-Based Education and Exercise Intervention for Degenerative Meniscal Injuries awaiting public orthopaedic assessment. So this is a journey for me that's been a couple of years in the making. I saw a problem that was occurring with our orthopaedic waitlist assessment clinic. And what I was seeing was that we had this enormous waitlist, and at the time where we took the data, there was over 2,000 patients. The highest proportion were hip and knee osteoarthritis, which we were managing quite well through our orthopaedic waitlist service. But I was seeing that we had this huge proportion of meniscus injuries at 15%. And what I was quite shocked to see was the waiting times that people had been on our waiting list, 43% more than 2 years. We had this cohort of nearly 20% that had been beyond 4 years. And what I was seeing when I had a chat to a few people through our innovation acceleration program was that many weren't having any meaningful rehab while they were waiting on our waiting list. So I went back and conducted a literature review to see what the actual evidence said. I had my own bias on it, but I wanted to see what the literature showed us. And I wasn't shocked to see that non-operative management wasn't superior to, operative management wasn't superior to non-operative management for this cohort. And that was for both pain and level of function. And that was, it actually, when you read back through the data, there was actually strong recommendations against operative management for degenerative meniscal tears. The literature was strongly in favour of a trial of at least non-operative intervention first. And that was reflected in major worldwide guidelines. This one from the British Association of Surgery for the Knee, where they give quite a comprehensive management guideline. basically for our degenerative meniscal cohort, there was only one urgent or strong indication for surgery, and that was for an acute locked knee, which is a pretty rare presentation that often presents through our ED. We might see a couple a year. For otherwise, it was this middle cohort that should trial a non-operative management, and if they have ongoing symptoms, might be considered for an operative management. But the most obvious part was this bottom part, where it was the degenerative cohort that had any sort of signs of osteoarthritis, where there were strong recommendations against surgical management because of risk of progression to total knee replacement. So what I did is I actually took my idea and applied through the Innovation Acceleration Program, which is a 12-week accelerator program that Behaviour Health was involved in with Melbourne University. And through that program, got to work with a team of worldwide leading researchers in the knee field, and basically throw some ideas around about what we might do. And what we sort of come up with was this idea of a waiting list intervention, where we try a digital-based education and exercise program aimed at the waiting list, and hopefully we hypothesise that a certain percentage would improve and hopefully no longer need that service. And the idea being that hopefully we can target it as a direct measure at intake, rather than waiting 4 or 5 years where we see that deterioration. And through that program, I was lucky enough that we got some funding, and we got over 33,000, and Kylie's in the room, and she was a great part of this, so thanks, Kylie. But we were able to get some really good funding to push forward with the idea. And so what we've decided to do with that funding is we're currently running a pilot randomised controlled trial, to look at the feasibility of trialling a bigger study, but also to see, does this actually work? Is it going to be effective? So we're looking at trying to recruit 66 patients currently off the Behaviour Health waitlist in that 40 to 60 age bracket, with unilateral knee pain and an MRI confirming degenerative meniscal pathology, but excluding those with the locked knee that probably need the urgent surgery, any associated knee injuries, those with significant knee osteoarthritis, or if they've had ipsilateral, so same-sided knee surgery in the last couple of years, anything that prevents them from partaking in an exercise program. So what we've been doing is we've used block randomisation using a computer-generated sequence to randomise to our groups, and we've concealed that allocation, and we're blinding our statisticians to allocation. So our 3 groups, we've got our first group, which will be offered just the 12-week education and exercise program through the PhysiTrack software. So as they're assessed their eligibility, they'll be offered that directly, and off they go. Group 2, as a matter of difference, we're trialling a face-to-face assessment with one of our orthopaedic waitlist physios first, to see if the added assessment and reassurance adds anything to our program. From there, they get offered the same digital program as Group 1, and then we're running a waiting list control as a comparator to see what the natural history might be going through there. And we're taking outcomes at baseline, 12 weeks, 24 weeks. So the 5 things that we're sort of targeting here are our global rating of change scale, so the really subjective, are you improving or not improving, the KOOS-12 and the WOMAT, which look at knee pain and function, the Euroqual, and then having a look at just how many people elect to discharge from our waiting list. Is this an effective thing, or is it just a time, something to keep them busy while they're waiting? So hoping that we see a percentage that want to discharge, and it helps our orthopaedic service there. Where I'm at currently is we've got our ethics approval through, we've got our trial registered, we've got our site-specific assessment, and we've just started recruiting in the last week. We're up to... Thank you. Got 4, so 62 to go. But yeah, it's an interesting thing, and I can see a lot of applicability to a number of orthopaedic conditions following a similar, a similar method. So I think this might be the tip of the iceberg. It's something that I can see being broader and could change the way that, the state at least runs its orthopaedic public waiting lists. So yeah, where could this trial lead? I've said it's the first trial that I've been able to find that's looked at implementing an intervention strategy at a orthopaedic waiting list, and particularly a public one. And like I say, I think there's translation to many other conditions which could lead to some form of elective surgery reform. Now, I haven't done it all myself. I've had some brilliant help. We've just heard from Dr. Steve Barrett, who's very, very knowledgeable in this area. So he's been a great help in getting this going. But also now Dr. Josh Norton and Theo as well, who have given their support, looked over a lot of documents for me as well. So not an individual performance, has been a good team backing me up behind. Thank you. How come Steve didn't get all the questions? Steve didn't get all.
Can I just ask you a question about Theo's work? I was involved with Theo's work for some years ago, and I thought that was a similar area of looking at the waiting list. So what have you learnt from Theo's work that's informed yours?
We haven't really looked at Theo's old published work. It's more, Theo's been there more as a bit of a guidance, and he's helped, I guess, with the exercise program we've come and put together and the education program. So he's been more like an editor on those.
So there's a database. There's a database that he asked me to update just yesterday, as it turns out, synchronistically, to expand their work in the waiting list, and so that data is available to you if you'd like to review it. Mm-hmm. And say again. Mm. Oh, excuse my gross ignorance. I thought it was a similar area.
So I'm guessing that's looking at hip and knee, yeah.
Same different area.
Yeah, exactly.
I'd be really interested as well for those that can stay on the waiting list anyway, if they actually do better post-operatively if they do go on, because I suspect it would act as prehabilitation, motivation, increase in exercise, improved muscle strength, all of those things that would have better outcomes anyway.
Yeah, you would strongly hypothesise that. Yeah, absolutely. So there's great evidence for prehab with most of those type of orthopaedic conditions. So yes, you would hypothesise that. Yeah.
I have a slight answer to that one. We found with the osteoarthritis, the ones that went through the exercise program had improved outcomes post-operatively.
Oh, there you go.
We did a study on that at the end of Theo's project. I did that one.
Thank you. This is not so much a question as a comment, but as someone who's had significant knee surgical intervention and non-surgical intervention myself, I have lots of conversations with people who experience knee pain, and I know that a lot of them will avoid contacting any sort of health professional about it because they think the only option will be surgery and they don't want that. So I think in terms of promoting this as an alternative pathway for people with knee pain, I think that's excellent. And the more it can get out there that there might be an option for people within their public health system that's not surgery, I think the more people you'll have come seeking that.
Yeah. We've had probably in that week where I've been phoning people to try and enrol. It's been mixed. There's been some that have been quite angry at their lengthy wait, which is probably fair enough. And there's been some that have said, "Oh, great idea. wish you could have got to me 3 years ago and that. So, yeah, I think as an alternative model of care, I think it works, yeah.
Hi, Ryan. Well done. I'm really looking forward to watching the full journey on this project. I guess my question is just around the IAP, so the Innovation Acceleration Program was really about taking clinician-led problems and creating intrapreneurs and entrepreneurs. So I'm really interested in why you applied for it.
It actually went with a and I think the Innovation Acceleration Program was, it was promoting as, even if you have the problem, bring the problem along, even if you haven't got the solution. And that was probably something I had the problem on going, we've got heaps of people here sitting there doing nothing, we need to do something with them. And yeah, so I took the idea in, and then it was when I worked with those researchers from Melbourne that we sort of went, well, why don't we actually, rather than sort of, you know, another online thing that sits there, and they exist for knee osteoarthritis, there's heaps of them. They said, why don't you actually target the waitlist direct and see what sort of effect that has? So does that answer, sorry, I don't know if that answers the question in the end. Yeah, I didn't really have a solution, and yeah, it was when we sat down, we started brainstorming that, yeah, it was, why don't you actually target the wait list? It will give you best bang for buck for the health service. And yeah, I went, actually that makes a lot of sense. So yeah, that's where we worked with that.
Any more questions? Very much so. Look, I think this afternoon's been a bit of a showcase of how much we can achieve too with academic partnerships and collaborative research with Uni Melbourne, La Trobe, our other partners, of course. So I'm not going to stand in the way of our hungry attendees an afternoon tea. So go enjoy. Speaking of our supporters and sponsors, enjoy Trial Docs and have a look at their site docs platform, and Walters Kluwer are there to talk to you as well, and of course our supporters VCCC and RCCC. So, and be back at 3:10, ready to start at 3:15, please.